So now I call my dear friend Dr. Rajani Battu. She has come all the way from Bangalore to join in this IC, and it is an honor for us to have her here. She is the Chief Medical Officer of ISTEM Research and a Senior Consultant at Aster CMI Bangalore. After her MS from St. John's, Bangalore, she had her FRCS from Edinburgh, training in Vitreoretina from Shankara Netralaya, ICO fellowship from Moorfields, and a PhD in inherited retinal disorders from Maastricht University, Netherlands. So she is going to share her experience with us. Over to you, Rajni. Welcome you for this
Thank you.
IC.
Thank you so much, Lekha, and KSOS for this. When I hear this, it looks like I've only been studying and doing nothing else. So, okay. So, my previous speakers have done this, my job, really simple. All of them have really touched upon why we need to do genetic evaluation, but I'm just sort of going to organize this a little more. So, we've heard all of this. So you can have mutations either in the RPE, in the outer segment of the rods and cones, or the inner segments, and in any of these, biochemicals of the visual cycle. Now, I'm not going to touch upon this. We've heard enough of all of this. Now, why do we need to do a genetic testing? Of course, for a precise diagnosis, because it's like someone having fever for a few years and we don't know why it is so. So having a precise diagnosis helps in prognosticating. It's easier to tell a patient, how long they're going to be able to see. Because I think one of the biggest questions, major questions that patients have is, even if we're not able to treat them, the question that haunts them is, am I going to go blind? If so, when am I going to go blind? How many years do I have? So, to a large extent, doing a genetic testing does help in prognostication and definitely to look for possible therapies. I think because this field of genes, and genetic therapy has exploded in the last, decade or so. So, I do think there's a lot on the anvil. And most importantly, I think Dr. Divya mentioned family counseling or prenatal diagnosis. I'll just touch upon a few cases just to explain each of this. So this is, two sisters, non-consanguineous, parents, lawyer, parents, and the older one was a very shy 8-year-old girl, had a fever for about a week, following which she said she wasn't going to go to school. So two examinations done. Incidentally, this child is from the US. Two examinations done in the US, both showed that the vision was about 618 seen by I think general ophthalmologist and felt that there was nothing wrong, and the fundus report normal. The child was actually referred to a child psychiatrist. So on examination, her vision was about 624 each eye, not improving. Anti-segment was normal. This was a fundus. While on first look, it does look completely normal. There is a bit of a sheen at the macula that you can make out. Maybe it's also because we see a lot of these children. So when you do the autofluorescence, look at how enlarged the area of hypoautofluorescence is. So this is why I think my previous speakers were also telling us how important autofluorescence is in examination of children or adults with unexplained vision loss. So when you do the OCT, you see this significant loss of photoreceptor layer all throughout. And remember, it's only an 8-year-old child, and her full field ERG was difficult, but they found it was normal. So the diagnosis was varied. A diagnosis of autoimmune retinopathy was made, whether it was retinal dystrophy, whether the child was malingering. In fact, this child was told she has autoimmune retinopathy and advised a whole body, a PET CT to pick up any malignancy. So when I saw this child, to me, this was a retinal dystrophy. And eventually what we found was that this child did have two mutations in the ABCO4 gene. So this is an early onset Stargardt disease. And I insisted that I examine the 5-year-old sister. The parents were hesitant, saying she's completely okay and there was no need. But the child had no complaints, cheerful. Vision actually improved to 6.6, when we treated her for her amblyopia. And this was her fundus. Anti-segment normal, this was a fundus, a normal looking fundus. Now, when you do the autofluorescence, there is a mild enlargement, but I wouldn't really give it too much importance. But here's what the OCT showed. So do you see this thickening of the ELM? So this is very characteristic of a subclinical stage of early onset Stargardt disease. Now, again, unfortunately for the parents, this child also had two mutations in the ABCA4, and this is a very distinct entity. Early onset Stargardt disease, I probably in the last 15, 18 years have seen at least about 6 children with early onset Stargardt who don't get diagnosed in time because the only a symptom they come up with is blurred vision. And unless you investigate, you can't make out that there is something wrong at the macula. So they typically present between the age of 7 and 9, and abnormal autofluorescence and OCT. And unfortunately, they have quite a bad prognosis. So the ELM is, one of the hallmarks in early onset, Stargardt disease. So these children tend to drop very rapidly to about 660 by the age of, 12 or 13, which is not the usual case with, the routine Stargardts that we see. So we've heard enough. This is how we, see a typical retinitis pigmentosa. Now, what happens if it is not, what we see as a typical, the bony spicules, the arterial attenuation, waxy pallor. Now, this was a builder's son, a 25-year-old, a builder's son from Bangalore. He had actually undergone LASIK because his vision was poor. They had some, refractive error, had undergone LASIK. He basically came with difficulty, headaches and difficulty in vision, and consanguineous parents and only son. And vision was about 660, not improving, and really vague, refractive errors following the LASIK, unfortunately. This was his fundus. You don't see anything typical. In fact, what you will see is probably what looks like, a coats-like appearance there. That's in both the eyes. And even the autofluorescence is not a very classic, retinitis pigmentosa. And again, on the OCT, if it's a typical retinitis pigmentosa, you would sort of see the central preservation of the, outer segments. Here, there's a diffuse loss. So ERG did show a significant, rod dysfunction. And so this patient had what is called a CRB1 mutation or a Crumb's homologue. It's important because these patients, again, unfortunately, lose vision quite rapidly. And one of the hallmarks of them in the OCT is a very thick OCT that you saw. If I go back to the OCT, look at how thick the OCT is with sort of very diffuse lamination compared to a normal OCT. So this is very characteristic of a CRB1 mutation. CRB1 can also cause a form of LCA, but this gentleman had retinitis pigmentosa. So this is, this case is a diagnostic dilemma that I think a lot of people have heard from my, enough number of times, because I still want to talk about it just so that we don't miss these, patients. This was one of the first patients that I saw, a 20-year-old who, was being treated for bilateral panuveitis and angle closure glaucoma, had been on steroids and azathioprine for a few years, and on maximum medical therapy, significant vision loss, unfortunately. As you see, a very, very shallow AC, in spite of it, there is a YAG iridotomy that you see there, and that's the typical fundus. I'm going to do a close-up. So you see these changes at the macula, which is sort of vitelliform deposit, and the significant, disc cupping, of course. And when you do an autofluorescence in these patients, you see this significantly lit up macula. And the OCT will, of course, the angiogram was not, anything significant. When you do an OCT, you see these not only intraretinal fluid, you'll also see the subretinal fluid, and these sort of typical hanging, outer segments that you see. This is very characteristic of the recessive BEST that I think Dr. Lekha had alluded in another talk. So, of course, this patient had, while there was a rod cone dysfunction, the patient also had an abnormal EOG. These patients are very typically, they present to either the uveitis specialist or the glaucoma specialist. So they do not present to the a retina specialist. They carry a recessive BEST gene, unlike Dr. Lekha showing you the dominant vitelliform, the yellow lesion that you see at the macula. These patients typically present to the uveitis department. And I remember when I started looking at these, a series of patients, I picked at about 12 patients in a matter of a year, all of whom were being treated for glaucoma or uveitis. And so it's important that these patients are diagnosed correctly. Of course, we did a genetic testing and we did find that this patient had 2 copies of the BEST1 gene. One of the important aspects of this disease is that 50% of patients have only angle closure glaucoma in the absence of a retinal finding. So it's very important to really look at the extended families in these patients. So at least you treat the glaucoma, and even if they don't have a retinal finding. The second important aspect of this is these patients typically don't do very well either with the trabeculectomy. Most of them will require an anterior hyaloidotomy, which is when both the AC settles and also the retina. So that's another important bit of ARB. Another 2 sisters. This is, the older one was, I think, they're now 17 and 13, consanguineous marriage. How do we look at therapy? We looked at diagnostic dilemmas. What happens as we go ahead looking for therapies? These are two children who present typically with, what looks like LCA. The fundus is more or less normal. So this is very characteristic of the RP65 gene that, we all talk about, Luxturna and, gene therapy. So this is how these children present. So this is the older sister. And what is also important is how well the retinal architecture is maintained, unlike other LCAs that you see where there's significant loss of rods and cones. This is in fact one of the reasons why RP65 was picked up for the early gene therapy that we are aware of. So significant field loss, significant loss of rods and cones, as you can see. Sister, again with a similar vision, and look at again the retina. If this child went to another, for routine examination, the child would be told that fundus is normal. So similarly, very, very well retained outer retinas, significant loss of rods and cones. And both these children carry 2 copies of mutation in the RP65 gene. So as gene therapy has become available, unfortunately for us, Luxturna is not going to be introduced to India. There was a time, I think the last 1 year, that a few of us worked towards its being launched in India, but it does seem like it's not going to be launched in India, as of now. So this is one of the last cases. So we spoke about why therapy and then, diagnosis and then therapy. This is for prenatal diagnosis. So this is a family of multiple members who are losing vision once they reach middle age. So you can see it's an autosomal dominant. So this is the gentleman who came to me. His father is about 75, 73 years old. That's his fundus with a significant, vision loss in both eyes. And this is a condition called late onset retinal degeneration, and we identified that he carries a single copy. That's an autosomal dominant disease, and this is a son. The son was quite hopeful he would be okay, but when you look at these changes, you know that he's going to be a carrier of the same mutation. So unfortunately, he carried the same mutation too. Now, he was about 37, 38. He wanted to have a child. So how do we ensure that someone with an autosomal dominant disease has a child who's unaffected? So if the normal pregnancy, there's a 1 in 2 chance, whereas today you can do an IVF, and then, so there is something called pre-implantation genetic diagnosis that can be done. So what is done is, an IVF is done and a biopsy is taken from the embryo at the 8-cell stage. And then they are subjected to something called PGTM and PGTA. This was one of the first cycles that they did where every single one showed that there was an aneuploidy. That means if they had an IVF or normal pregnancy, I think a very high chance that they would have had another child with a similar problem. Thankfully, they actually got an IVF second time, and they found 3 embryos that were not affected, and they eventually went on to have a normal child. So I'm going to skip some of this. Maybe we'll discuss this in the therapy part of it. A lot of us have touched. We'll discuss this in the discussion bit. Thank you so much.